Clinical Professor at LSU Health Sciences in the Department of Psychiatry. Thank you, Dr. Hemphill, for taking the time today to share with our guests from around the nation. Your knowledge and expertise, we appreciate your time. Now let's get started. Over to you.
Yeah, thank you very much, Allie, for that introduction. And thank you to Lakeview Health for inviting me to provide this workshop. It's an annual workshop that we have done for about the past 5 years on ethics. And unfortunately, this year, we're not able to be in person, but we're capturing a much broader audience. And for that, I'm very grateful to the staff and the administrators that provide excellent care to patients from across the United States. I'm really happy to be able to come to you from New Orleans today. Despite the cancellation of Mardi Gras, I still have worn my Mardi Gras bow tie, just in the spirit of the season for us at least. And I know that many people are affected around the country by the current weather conditions, and I hope that you stay warm and safe throughout the day and throughout this morning. So maybe if you're driving, listening to this, be cautious. The roads are perhaps slippery. So I'm going to share with you my experience that I've had in my career and the things that I've encountered related to understanding and working through ethical decisions. I'm going to start off talking a little bit about us as a profession and you as a professional. And then we're going to move into some of the ways in which we sometimes need assistance in with these ethical experiences, or at times when there are breaches in our ethics. And then I'm going to talk about the impact of working with individuals with addiction and how that affects ethical decision making. So this is going to go straight through for about 2 hours and 45 minutes. If you have questions, you can begin entering them throughout the presentation, and at the end, Allie is going to moderate the Q&A, and she's going to ask some of those questions, and I'll do my best to answer them to the best of my ability. But I want you to know that that's the form of interaction that we have here today, and it's the situation as we do this webinar online here. So I've mentioned my objectives in the outline. As a good educator, I try to have some goals here, and I really have no disclosures in that what informs my lecture here is my clinical experience, and Allie has reviewed some of that. However, it is a bit skewed in the population and the sample of individuals that I've worked with over my career. So I will be limited to some of those experiences and exposures. And while I may not have the same personal experience as you as a professional, I think that there's an umbrella of expectations of quality care that we're all delivering. So even though I may be speaking to other areas that you may say, oh, I'll never treat someone like that, or that's not really what I do, I would ask you to have an open mind, try to apply it to your particular scenario and your particular case. The other component is that there's multiple disciplines on this call. So the idea that people have different boards and license and ethics that they have to follow is certainly something that you have to adhere to with regards to your own profession. And again, I think there's more commonality and overlap than there are differences in the course of this discussion. I like to put it out there just at the very beginning that a lot of practices have shifted and have been very agile and started deploying services online. And even if they're not doing it full time online today, they're in a position where say, for example, with a weather event, there can easily be a shift to doing telehealth services. So these are, I've attended a number of presentations in the past year, but these are some of the resources related to the best practices of telehealth. And of course, COVID pushed us in this direction. And, I would invite people to consider. I know the different professions have adjusted their code of ethics and bylaws with regards to expectations of professionals, but certainly there are organizations out there that have been doing this before COVID and setting up guidelines, best practices. And so I just want people to know that there's a plethora of resources for platforms, for health security platforms, which is a big thing these days, because when we're doing telehealth and where people are in their lives, in their space, is it really confidential, these types of things. So that's something I wanted to do as sort of a public service announcement. And again, all the things that I referred to have to do with elevating the level of professionalism and interaction, including the access to care, which we've seen in a number of studies talking about people with addiction having better access to care through telehealth, being more engaged, showing up more for appointments because there's not the need to have to drive to and from. So I think that some of the impact is going to be here to stay, but I do see people sort of migrating back to the on-site or live in vivo practice. So again, as this has shifted, the reality of technology entering into the workspace has had an impact. Initially, we use technology just as a way of being compliant and, for an administrative purposes where we could track things. We sort of created spreadsheets and came up with ideas of how to be clinically efficient and, providing surveys, let's say online, these types of things. And then we moved more into a compliance where we would say, how quick is a note done at the end of the day? Is it within 24 hours? Is the psychiatric evaluation, the addiction assessment, is this done within our protocol, which could be 72 hours, could be 5 days, not sure what the organization has. And then now it's much more a platform to be competitive in our field and our industry, because the expectation is that we're using this to not only assist the patients, but to make sure that we're maintaining a competitive edge and having access and increase in engagement with our patients and clients over the course of time. When I was writing my dissertation, I carried this quote around by Karl Popper in my wallet, and it reminds me of keeping an open mind, that once I sort of think I have things figured out, I realize that my theory doesn't have much to stand on and that I need to learn through its failure. This was glaring to me personally this past year with the injustice that took place in our society and the impact that it had across the nation on individuals, groups, institutions. And it required a re-examination of my own ideals and beliefs and values. So that's just one example. But I would ask you today to keep an open mind to the realities of some of the things I will be presenting, because I have a tendency to try to shake people up a little bit, sort of like the snow globe, and seeing where the glitter falls. So as I've already mentioned, this is really about the way I see it. I have the mic for 2 hours and 45 minutes. Lakeview has given me that. I've prepared a lecture. You're in the role of participant today. But the reality is that you see this, you see these dilemmas, you see these perspectives, and it's just as valuable, just as important. And obviously, the truth is, the way it really is, meaning like the combination of these things. So we have different perspectives as it relates to some of our opportunities for growth today. So what about professionalism? Where is this? Why is it that we're sitting here today? Maybe we're up against a timeline for making sure our ethics 3 hours are met at the beginning of the year here. But there's ways that you can get ethics just by reading a book or reading a couple of journal articles. So there's something about you that sort of drove you to listen to a webinar, or the notion of a timeliness. Well, where does this come from? Well, the expectation of professionals is that, the core element is our ability to master a complex body of work, a complex body of information, and develop a skill set that is complex. So really the expectation is that we're continuously striving for mastery over this process. And this could be as new theories come about, as new treatment techniques come online. We have to stay up to date and maintain our complexity there. We are based as in science, so that we're looking to scientific evidence. We're looking for evidence-based practice. We're looking for data-informed care, to deliver data-informed care. So we have to commit to the science of our industry, of our field. At the same time, the use of integrating the practice of art. In a profession, we're doing this in a creative way. We get to tap into our own creativity as it comes to dealing with patients, dealing with families, dealing with groups, dealing with communities. We have to be able to be strategic and creative to be able to provide this service to others. Lastly, number 3 here is that we all have codes of ethics that we're expected to be governed by, and make a commitment with integrity to this competence, to understand the morality, and have a commitment to our delivering this care and promoting the well-being of public good. So that's sort of the definition of what professionals are and what we bring to the society. So really, society, the reason we exist is because society really needs and wants us. Meaning, like, not everybody can do this. Not everybody puts forth the effort of, procuring a professional degree, going through the process, being, committed to studying, and committed to procuring not only the degree, but your license, and moving forward with that. What this does is it creates a sense of trustworthiness that this group of people, this individual, has gone through the process. And therefore, this trust is given, and there's status involved in that, and that you have access to information that most people do not. You have the ability to retain that information, the ability to discern the information, the ability to deploy the best practices. So therefore, there's a sense of trust. And lastly, it's about not only you as an individual, but you collectively as the group of individuals you belong to. So the ways in which things take place with regards to any breaches in ethics or any handling of ethical decisions not only may affect you as an individual, but it affects the whole group of people that you're affiliated with, you're associated with, you're part of a collective group with, not only say in your practice, in your organization, in your institution, but as a governing body of your license. So these are just why it's, the reality that there's trust, and that we are really and that society needs us to deal with certain types of issues, and especially today, given the pandemic and the impact across society. The mental health profession is in really dire need in a lot of ways. So that's why you see a lot of technology coming online to try to deploy these strategies to reach the masses, because it's finally becoming it's coming to head that really there's a huge need in society, and I think some of the stigma has been reduced because of this. So just at the time when we have this need, in the past couple of years here, we've seen a distrust of people in hierarchy and people in authority. And we've seen movements take place, and the confrontation of authority figures and people being held accountable when they cross these boundaries and cross these lines. And so despite these efforts, and they've been very public, there's still society and our professions are still fraught with boundary violations, egregious practices, and harassment in the workplace, harassment in healthcare. And my colleague and I, Dr. Alexis Polis, did a presentation on this, and the reality of how it's very common in the STEM fields to have harassment, sexual harassment, that in medicine, on sites or across sites and disciplines, as a prevalence of this. And these things really have an impact on obviously the individuals, but actually the care delivery to the patients, the not wanting to show up for work, not wanting to contact someone who may be in authority because out of fear of the repercussions of contacting someone. So there's many different ways that this can affect individuals and the system of care delivery, of healthcare. There are, certainly despite continued devaluing of females in the workplace, despite females being the predominant population, with regards to the healthcare field. There's still power dynamics that are different. These have not gone away, despite some of the efforts that have been made. My colleague Margaret Reynolds and I published an article last month in January about the sexual harassment and in higher education, and it was in the graduate student population and in the medical student population. And it was a review article that looked at it was sort of a weather bell to say we still have a lot of work to do. We have a heavy lift going here, and we really need to push forward this agenda in our institutions. And the people who are in charge need to take hold of this and expect that this is taking place. Not that it's a rarity, but yes, this is going on. So, harassment actually can come obviously laterally from coworkers and vertically from people in hierarchy, but we're also seeing clients being harassing, and some of their language, some of the questions, some of their physical touch type things. So, we have to look at this across the spectrum with regards to a hostile environment at times. So ethics they help us make decisions in the workplace and our community, and then that's a little different than the actual laws. So we know that the interface between these two are sometimes conflicted, and this is where we have to often seek out sort of consultation from our peers to say, this doesn't seem right ethically, but is it really against the law? Some things rise to the level of being against the law and are protective, but we have to acknowledge that these are differences. that we have expectations in our profession that may not necessarily be illegal. And, this hopefully guides our conduct as proper behavior and, commitment in these different settings. You know, we have an expectation of providing for others. The fundamental activity is providing care for clients, and anything that interferes with that, that impacts that alleviation of suffering, is problematic. Okay, and this is about placing others' welfare ahead of our own. I mean, that's really the altruism that we've signed up for. And, we've gone down this path and we've committed ourselves to place them ahead of us, ahead of our needs, ahead of our interests. And that is the key point in this presentation. There are different elements of this that I will be presenting throughout the discussion here. So what about people who do cross over that threshold? Well, I don't know if I'm sure you're familiar with the Hippocratic Oath, but what about the Hippocratic Curse? Well, I continue to keep this oath unviolated. May it be granted to me to enjoy life and the practice of the art, respected by all and in all times. But should I trespass and violate this oath, may the reverse be my lot. And so the idea that there are egregious consequences that are rippling throughout a system, an individual's life, throughout the perpetrator's experience, and the things that will follow their egregious violation certainly comes to fruition with individuals who violate these boundaries in the context of practicing. Let's see. For some reason the next one's not showing. Oh, I see. It goes a little bit slow here. Let me back up. All right. You see this one? There we go. So this slide is really about why other professionals sometimes have difficulty receiving feedback about ethical issues, dilemmas, observations that others may have of them, impact across a system. And so the reason here is that most of us are used to being in control. We're accustomed to being able to determine what's going on, the pace that we're working, the schedule, the things, the people we're interacting, the consults that we're doing. We're used to being in control with regards to our practice. We actually have been able to understand how to manipulate rules. And this may be like charting. What's the minimal amount of charting we could do to get through this? What's the minimal amount of time? What's the maximum? So, we know how to manipulate rules. There's a certain sense of, grandiosity as a professional. I mean, I can't really see how many of you are on here, but I was told that quite a number of people signed up. I mean, we expect about 50% of the people to actually be online for the webinar, but there's a certain amount of, hey, I'm important. Look at this. I'm doing this presentation today, and people are coming to see me for a couple of hours. I have something to say. This is just a presentation, and I'm using myself in a grandiose way. But the reality is somebody's like paying you for your services, paying you to spend time with you, paying you for your intellectual capital, your deployment of care for that individual. And that comes with some sense of elation, some sense of authority here. I'm in here at home. I can't get my kids to pick up their clothes off the floor, you know? So the reality is a lot different sometimes in our professional work versus our personal. We have the defense mechanism. We've mastered intellectualization where we can explain things away a lot of times and have the ability to sort of have, well, I understand what's going on. I really don't need a third party to give me feedback on these things. We often discount our feelings or our needs. I really don't need to take a day off. I really don't need to take a half a day off. If I have this space in my schedule, I have to hurry up and fill it. We often discount the impacts that work or being professionals or just being a human being have on us. Even, we've seen tremendous focus on burnout and healthcare, and that's been exposed significantly this past year. So I think there's a reduction in stigma, but at the same time, people still are pushing forward with these. There's also a fear that I may be discovered or I may be exposed. So again, that may be an element of resistance to things. Using like, oh, I'm just doing this in the best interest of the patient, sort of an overvaluing of the patient to justify one's behavior. And then there's other emotions that people may be afraid of to express and just fear of disapproval from institutions and colleagues and peers. So these are just some things that we've seen over the years. Professionals have a difficult time being resistant to understanding how if they're drifting in their ethical application, whether it be a boundary issue with a client, whether it be an emotional state that they're in the office, in the treatment process, whether they're reacting to a certain client in a certain way, any of these types of variables that we are sort of posed with regards to ethical issues, these could potentially be some barriers for people being able to be successful. So, the reality is we're a self-selected group. Somehow we've gotten ourselves through the training. We've been elevated. There's been competition to get here. There's continued competition out in the workplace, out in the public market for work. We sort of sometimes have to have like this superhuman expectation of what needs to be accomplished, and we got to CCC patients. We got to work, make sure we're reading up on the latest information. And, we have this illusion that somehow we can have this objectivity, like the realities that we don't have an impact or an influence on our processes. And that's not accurate. We have a profound impact. So let's see. Got to click for this one. So I think the training and the early stages of a professional's career can be traumatic, and being exposed to the types of things that you may not have expected in training may create some similar to PTSD types of experience where there's hypervigilance, there's avoidance, there could even be flashbacks. I mean, I certainly remember in the early stage of my career, the having dreams of things that I had heard, or at least things that could be possible in my own family, not really wanting to have that present, but certainly knowing that part of this was in the indoctrination into the profession, and these things being a part of you being a receptacle for a lot of pain and anguish that individuals bring to you. So, there are characteristics of professionals who choose to go into healthcare, into counseling, into working with addiction. It's okay to want to have some rewards for our services. Sometimes we think that we don't deserve to be paid, we don't deserve these types of things, but in fact you do, and that you're elevated. And if you you work you do something that's very valuable, something that's very powerful. You give a lot of yourself, um, and you deserve the esteem, the status that comes along with the profession, the privilege that you have of access to information. There's power involved in this, and there's financial reward. There's nothing wrong with these things being a component of professional identity, professional services being delivered. I think I've found in mental health and addiction, people sometimes have this idea that it just has to be about altruism. That's not accurate. Internally, I still have colleagues from when I first started in the field or when I was in my training. So I think the legacy of relationships is very important with professionals, and making sure that you have the ability to endure, because your capacity for endurance gets broadened over time as you have more and more cases that you have to manage, or you have a history with more and more cases. As the years go by, you have more people that you've dealt with in the past. So these are just some of the characteristics of professionals. Now, I've seen the difficulty sometimes with professionals who believe that they just have to try more. They just have to run a little faster in that hamster wheel. They just have to run a little bit more on that. Have to hurry up and get to work. And it's, any type of failure is perceived as oftentimes, I didn't try enough. And therefore, that translates into having a difficult time asking for help or receiving help. So these are just, again, some general overarching issues related to professionalism. Back to the training, the competition, there's isolation in training, like the cases that you're dealing with, the individuals you're dealing with, even if you're on a team, your own personal experience with that individual, with that group, is going to be different than even a facilitator of a group or a different member of the interdisciplinary treatment team. There's an element of social isolation. Even when you go home, you're back in your personal life and you're expected to maintain all of your professional confidentiality. Then all of a sudden you're expected to transition back into your personal life, and you may still be affected by the work that you did. So therefore, again, there's an element of mental isolation that you can't really reveal to people in the grocery store or people who you may be interacting with outside of work, what you dealt with throughout the course of your day. A lot of self-neglect here, this idea of cynicism, people are so mean to each other, suspiciousness sometimes creeps into it. That person's probably doing this, or that person has this. So that could be a part of the impact through the training, as well as the impact of being a professional. And so family issues, the conflict in your personal values versus your professional values may come about, as well as just the idea that I've already mentioned about the lack of limits, depression and emotions, this kind of thing. So these, the last one there, the adversarial nature, this may be that we may take a very defensive posture in the way we chart, in the way that we interact, because there's sort of a fear base that maybe we're somehow not, that this may end up in a legal situation, we may end up having to defend ourselves, this kind of thing. So sometimes that may be the position that takes place through training and through the continuation of our practices. So about now, I'd probably ask people to say, hey, we've been going at this about 45 minutes. So, is anybody, let's stand up, take a stretch, that kind of thing. So, I don't want to stand up and take a stretch, but I'll do what I can here at the seat, because, you might see my bedroom or wherever it is, whatever's going on here. But I just wanted to acknowledge that moving around is healthy. So I would be impressed if some of you are actually exercising listening to this. That would really impress me. But we've heard a lot about the social determinants of health. So I felt the importance of just acknowledging these in the course of the, pushing forward to wholeness, pushing forward to the complexity of what we're having to deal with, and how, we may get this very myopic view of what we're dealing with instead of looking at a much broader approach to the clients we're having. This, looking at these things, asking broader questions, considering all of these factors requires some balancing, requires more integrative thinking when it comes to, presenting this to clients and, being engaged with them and, being part of their educational experience, being part of their economic stability, being part of the context in which they live in their neighborhoods and social environment. So, having this, even though it's a model of health across domains, it stretches us in our own ethics and our boundaries as mental health and addiction providers. And so in the context of addiction, we have to look beyond just the suppression of the addiction or the increased time in remission or the abstinence, versus the non-abstinence. Whatever approach we have to bring in these complex domains here, which stretch, because then, once you start talking to somebody about education, you're sort of opening yourself up more to being able to provide some of the support in that. Therefore, somebody may say, hey, I'm graduating from Votech school. Would you like to attend my graduation? You helped me. You made this such a big part of my life. Would you like to attend? Then you have a dilemma. You have something that you have to consider. Am I in a position to attend this function? Is this a decision I have to make? So these are just some of the possibilities of ways in which, from a charting standpoint, from a delivery of care standpoint, are we practicing. Again, more of the ways in which the social determinants impact society and individuals, much more of a health approach. And so we have to familiarize ourselves, especially in the addiction industry, with the integration of health. And, as Ali mentioned, that's something I'm currently writing about and have a publication through Routledge Press in the works here, and therefore, integrating all of this, the complexity of all of this, is very challenging to professionals who haven't been trained in this area. And all of a sudden, we have to, familiarize ourselves in many different ways in the addiction industry, and not, be considered. We have to sort of challenge ourselves, and we have to extend our training, extend the expectation of knowledge to these different areas. This was an interesting study I came across with this in mind. So they did this complete wraparound service for these individuals for a protracted amount of time in the context of, core wraparound services, social determinants of health. And what they found at the end is that the people who had the most difficulties didn't really have stable housing or even access to a telephone. And so the complexities of the behavioral health were overlooked, despite a huge amount of resources being deployed to this group of individuals related to the complex nature of the social determinants of health and the wraparound services. So as addiction providers, in the context of ethical care, we really have to sort of embrace the concept of a health home. And so the idea that we're providing wraparound services really and truly stretches our boundaries and our deployment of care. And all of these different areas we have to consider, similar to those social determinants. But the key here is a home. It looks like a home. It's not that we put all these technology and all of these services and we're doing home visits. That's not what this slide's about. It's about we as professionals provide a protective environment that is fully comprehensive and supportive of the individual's entirety. We've been challenged too to look beyond just the idea of sort of cell theory, that somehow this came about from, there's a causal effect with substances and addiction treatment. And, we have to really integrate a much more comprehensive framework for addictive disorders, and looking at, the genetic variables, the use history, which is sort of the behavioral issues and how those have been reinforced and incentivized over time, how the emotionality of addiction has an environment, has a huge impact, a weighted impact, and then looking at environmental issues. And this is true across the industry. We're seeing it much more in the ways in which the brain is involved in the addiction process. So we have to at least familiarize ourselves with this, or we're not practicing the latest state of the art as it comes to addiction care. And it's expanding too around not just substance use disorders, but it's spilling over into the behavioral addictions as well. And I can see it's a little crooked here, but anyway, this is the epigenetics where things are being passed on. In this case, it's hypersexuality, which did not make it into the DSM-5, but is in the ICD-11 recently and called sexual compulsivity. But it's really about ways in which these things are passed on. And this slide really illustrates the importance of a comprehensive approach to conditions, especially with regards to the addictive disorders. So I just presented you with some of the sort of idealized expectations of a professional, where we came from, how we've kind of fallen down this rabbit hole of the Alice in Wonderland syndrome, and that we thought we were what we were getting, and then we started slipping down the hole, and it's really hard to catch ourselves along the way. And all of a sudden, here you are. So, I'm presented you with some idealized values, but the reality is we mainly live in a space of realized values, and that we're striving continuously for this. And we, maybe fluctuating, moving towards it, but we have to be more sort of forgiving and recognize the limitations, because these are very gray areas that that I'm referring to, and that ethical dilemmas and boundaries present to us in the behavioral health care system. And so give yourself permission to sort of be forgiving. Recognize that some experiences in your life may impact and influence your care delivery, your interpretation of a situation, and recognize that as long as you can come back to saying, yes, I'm still on that path and looking for the idealized. I'm still committed to this idealized. Still, like I recently just read through the NASW Code of Ethics just to kind of prepare for this. And it's like, man, these are like really stringent. These are legitimate. Now I live up to them to the best of my ability, and I refer back to them if need be. But there is more of a realized delivery system. So although I'm a social worker and I adhere to these values, you have the ones that you're expected to as well with regards to your specific profession, and I invite you to review those. It can be a bit of a sleepy read. There's a little bit of thickness to the language sometimes. Why most of us didn't go to law school, but the reality is that we have to continually familiarize ourselves not only with a presentation like this, but just remind ourselves. And I think that what really has brought the light to me is the influence of telemedicine. It's really made me go out and seek many presentations and journal articles related to the deployment of that to make sure that that's being done with these values in mind, in a sense of competency. Do I know of the latest platforms? Do I know of the latest boundaries? Do I know that I'm not supposed to be texting or using technology for personal communication with clients? Do I know what the expectations are related to telehealth and telemedicine? So I have to have certain amount of competency in that particular area. And that's just an example to consider with regards to how we need to stay up to date with our ethics and values and guidelines of our given profession. Diversity has been a mainstay in our industry, especially in deployment of care and addictions, and that we've been very accepting of many different professions and paraprofessionals and supportive individuals related to the concept of healing and moving forward. So the richness of cultural, professional, interdisciplinary teams has really been a wonderful deployment of capital in the space of addiction. And I think that has really helped the care of people, made people feel a sense of belonging, made individual patients remain engaged. They themselves developing those long-term relationships with people they met in the course of their treatment, in the course of their healing. These things have really shined through in the care delivery systems and healthcare, in addiction care. So, we have to sort of integrate the cultural richness, the diversity of individuals in the course. We have to be respectful with regards to all of these barriers that some people may face to having access and being retained within the recovery and healing process. So from direct care workers all the way to leadership, there's a need to maintain this cultural competency and cultural humility, where we're continuously in a state of learning and continuously in a state of growth. And that is the expectation, that we take that approach of an opportunity here. Well, we can get the idea of boundaries in many different places. They're available, across spectrum. As I mentioned, there's other forms of reading and webinars related to boundaries. You chose a live one today. As my understanding, you have to answer the questions at the end in order to get credit for this and get a 70. If I don't cover the material and you don't get a 70, then I really failed. So you need to email Allie and blame me, and I'll take that and I'll do my best to cover those topics here. But that's just a way of fidelity here, where we have to make sure that people are staying online and listening to the content of the material. So, because you're not in person. But back to the conversation here, that the boundaries are pushed in many different ways. However, society has quite a different definition of boundaries and the expectations. So what I've already mentioned is that there's a huge gray area when it comes to boundaries and it comes to problematic behavior, that it's not always binary, it's not always on one side or the other. So what really guides our relationships in life? We look at our own biology and our instincts. That's what just makes us up, our character and makeup here. Society helps us define the boundaries. They will be pushed. They have been pushed with technology, and there's different expectations today than when I first started my practice with regards to boundaries. So, these things have an impact or an influence. Our own ideals of what our internal working models are. So if we have a sense of trustworthiness, a sense that people are going to act on the best half, on their best behavior. If we project that out and expect that in others, we may have that as a working model and expect that from others. I recently had someone tell me a story about being scammed, and they said, this person was very educated, but they got scammed out of a significant amount of money. And, the reality is the person sort of had this ideal that the individuals they were dealing with were just like their inner circle of individuals. So that's their internal working model. And somehow they just projected that onto others. And that's just a society, somebody sort of an armchair anecdotal example here. But we have our own working models as professionals, and that's what guides our relationships. And so, make sure that we have awareness, continuous awareness, and that we're continually open to feedback. So ultimately, we want to do good, do no harm. We want to allow our clients with choice. We want to be fair and equitable. We want to identify people who need more support with empowerment, with those who are oppressed and have less access, that we extend even more, and we advocate for that, for their position of improvement in their position. And we want to maintain a loyalty to people, meaning like we don't abandon patients. We go through processes when we transition out or when we discontinue services, even if it's services for lack of payment. We all have these guidelines. I'm not sure if everybody on the call with all of your particular ethical standards and mandates are, but doing the right thing is the key here. And the reality is these are enforceable by all of our boards of examination across the United States, that we have these guidelines and standards that will be reviewed by boards, and they will have rulings. They will have a group of individuals that may support those who have difficulties with them as a way of getting the person back on track. So, ultimately, we're promoting autonomy in individuals. So we want to foster independence in our clients. We want to foster our ability to be responsible in the service of this patient's interests. And we want to, recognize that boundaries increase the likelihood of fostering this independence. So by individuals being able to experience some of these things, maybe at first they may be leaning on us a little bit more. As time goes on, there's more and more autonomy, more and more independence. There's usually, the idea of doing good and not harming people. That's what guides our practices. That's part of the ethical care delivery. If there's conflicts, we do our best to resolve those in a responsible fashion. So, for example, if all of a sudden find myself on a community board with a previous client that I had treated, I do my best to try to resolve that as soon as possible with regards to that dilemma. That would be sort of a dual relationship, unintended experience there. You may go get your car service. You may try to purchase a car, and all of a sudden the salesperson is your previous client. Okay, so these are things that may be unexpected, but we do our best to try to resolve those in a respectful and responsible fashion. So these are the things that we're doing in the best interest of others. We're guarding against all of these other gains that we may get. So say someone has insight into financial issues. We have to be cognizant that we're not bilking that person for information for our own good, so that when we get some intel, we're going to invest in that or something along those. We recognize, as I said very early, that this is a relationship that's based on trust, and we recognize that the individuals have rights and responsibilities, and then we avoid this unjust practice. We follow these rights and responsibilities, and we are open to a degree of monitoring, whether it be our own reflection or whether it be some external monitoring. That's where the fidelity comes in, and we sometimes have to have that articulated to us that maybe the fidelity isn't the best or isn't what we think it is. Therefore, we need to change our practices. So this goes back, here we are almost 30 years by Guttel and Gabbard talking about really a boundary is not a bright line. As I said, it's very gray. It's, it's this observation and understanding that, we try to make as clear as possible, but it's very unambiguous. It's very ambiguous, and we try. It's movable. It's highly context dependent. So, for example, if you are working in a battered shelter, or you're working in a sex trafficking, you may be much more likely to try and ask questions about a person's relationship or sexual history or sexually transmitted infections than a person who may be out in a general practice or maybe in a group setting. That may not be the same types of questions that you would ask that individual. So that's the comment there about the highly context dependent. There's not a hard and fast rule. So you may have people gather together and say, do you ask these questions? Do you deal with this? And you may say, no, I don't do that. But it relates to the context. I think too that boundaries with regards to social media, and this is my colleague Dr. Polis's observation here, is that sometimes like the idea that you have to present yourself in a certain way doesn't really maybe necessarily present in a neutral professional manner. And not that we have to be this tabula rasa, this blank slate, but at the same time, I think if I was to avail myself to this posture, that might be a little different, even on our webinar here, if I was to just lay that. That's why I put my bow tie on, my dress shirt. I actually do have like dress pants on, but it sort of puts me in that professional mode and gets me ready. Not a leisurely approach here to this discussion today, or to our professional practice. So, some of the ways in which these boundaries, the roles that people have, certainly here, obviously doctor-patient or therapist-patient, people in clergy, teacher-student, employee, employer, those are just the roles that we see boundaries needing to maintain a certain amount of being upheld. So we, as professionals, sometimes we think of boundaries as, oh, I don't want to touch my patient. So that is a physical boundary, but the reality is all of these fall into boundaries. And Dr. Abel pointed out, even our time is a boundary. Do we go over time? Do we stop early? Do we allow some people to go over and other people not to go over? So our role, we have many different roles. So when we're in the role of the clinician or practitioner, then we have a certain responsibility and expectation. But when I'm teaching my students in the role of a professor, there's a little different expectation there, a little different role that I'm placed in, but it's full of boundaries. It's very much a boundaried position, even to graduate students or medical students, residents, whatever it is. So our roles also are important. The way I am in a group as a facilitator is much different than the way I am with individuals in my individual practice. So that's some of the role boundaries that we have. Our physical space needs to be something as well. Now we have the telehealth onslaught here, but even this, with Allie, before we even started, I was like, is there a way I could put a different background here? But this particular platform, I wasn't able to do it. But normally in my um, Zoom and all these other Ring Central, some of these other platforms, Teams, I'll put a different backdrop here, and sort of my place becomes somewhat as professionalized as possible. So it's in a quiet location, the least amount of interruptions. That's sort of a telehealth. But our physical space, we'd want to make we want to make it look as a professional office. Some people are actually going out in the field and doing the work. So whatever it is, we need to recognize what our base is. Gifts, how we manage gifts. This is a boundary. Is the gift the value of the gift, the meaning behind the gift? I can remember as an intern in my graduate work getting a couple of gifts, and literally this being the conversation in my supervision for a month before I saw patients for an entire year. And at the end, they would give me gifts, and the meaning behind those and the value of them was used as a way of a platform for discussion. So, everyone has simple rules about gifts, looking at would accepting the gift be more detrimental than receiving the gift. There's different sort of equations that decision matrix that people sort of use when they deal with gifts. You have a policy where you just you tell the person any gifts we get, we share it with the whole staff. We put it in our kitchen area or something like that. Whatever it is and gifts may mean different things in different geographic areas, that kind of thing. The physical space, the work that I've done in my career has required substantial separation related to physical space. So not touching patients, maintaining, really good distance related to physical has been very important in the individuals that I've worked with in my career. Money as a boundary. Do you allow debt to accrue? Do you somehow, get a message. Sorry about that. Do you allow debt to, I guess Allie would step in if she needed me. But so back to the talk here, money, are you charging people an appropriate amount? Are you collecting the money? Are you allowing the accruement of debt? Are you setting a limit and discharging patients or referring patients out because you had a contractual agreement that they had to pay their debt ahead of time? Whatever your policy is, money is a part of this exchange. It actually helps keep boundaries, to be honest. Language, the more casual your language is, not only with the patient or client themselves, but as you consult with colleagues, the type of language you use can actually define and dictate what you're actually doing as far as the boundary that you have. So my suggestion is to keep the best professional language as much as possible so that you can maintain that boundary, as opposed to getting very casual in your description or your language with the patient as well. Respecting culture, and that we can't be proficient in all cultures, but we can recognize the uniqueness that each person brings in and the differences, and be, again, an observer and a partner and with this individual. This includes gender and race and ethnicity and all of these things related to an individual that we have to be open to. And then there are some geographic differences. As I mentioned, you may be in a more rural or urban area in addition to locations throughout. When do issues kind of come up? I think when clinicians have similar issues to their clients, when they're shared issues, sometimes that has an impact on the boundaries, because as a clinician, we may start thinking, well, that's not how I handled that, or that's not how it affected me. Why is it affecting them that way? So shared issues can certainly come up. I'm not saying that people with addiction can't work with others. These are just impacts. It doesn't mean that it's going to dictate the boundary, but it certainly can have an impact. So abuse histories, not having role models in people's developmental histories, just whatever your religious beliefs are, or orientation, or racial makeup is, any recovery model one adheres to, and just the idea that patients will often assume that the professional shares the same feelings. That's an assumption that is not uncommon of a projection that's made onto you as a professional. So a key takeaway from this whole talk is, if you ever believe that somehow you are providing special treatment, you're the only one that can provide this care, you're the only one that offers this care, then that can create serious problems, and that you've lost some objectivity. The word special is key here. Not that you don't have a unique relationship with this patient, because you do. In this moment in time, at this given moment in time, at this given treatment facility, at this given time, this given location, you were sought out, you had this interaction. It is unique at this moment in time. I'm not denying that. It is important. It is professional. It may be that at this time, this is what has taken place. I'm not denying that. But if you move into the realm of somehow we have a special relationship, and if I'm rotating off if I'm not on call this week, but I tell the person who is, hey, if so and so calls, I can deal with them. You don't need to deal with them. Just put them through to me. That's an example. Or if I rearrange my schedule to make sure that this person gets to have access to me, and I do this routinely. Not that you don't deal with people in crisis, but if it becomes a pattern and I lose some objectivity and I'm not open to feedback, that's an example of how a special idea of I have a special relationship. Our time management, our lack of awareness of our emotional state, especially as it relates to our interactions with patients, and then our response to them. And these could be some of the issues that come up from us as providers. These are some potential problems. Now, the clients may put us in a parental role. They may eroticize us. They may be passive aggressive at times. They may say, hey, we're the same. You're this, you're that. I know, I could tell. This is how your office is decorated. You wear a bow tie. I know. We have this brotherhood, this sisterhood, this this religious hood, whatever it is that we have, that can come sometimes from the individuals that we're working with. I've seen all of these things as a consequence when boundary violations occur. So the reality is they can have a profound effect, not only on the client and their systems, but across a spectrum of individuals and organizations. And that these are all the possible ways in which individuals I've seen actually have the consequences for boundary violations in the course of a professional relationship. So, there's really two different things here. A boundary crossing, which isn't necessarily a classical part of the treatment process, but it may not be harmful in and of itself, but it's definitely something that needs to be attended to. So maybe things are happening in your own life, and the patient picks up on that, and they ask you, do you have something going on? And you reveal that. That would be an example of a boundary crossing, where you're saying, well, I just had this death in my family, or I'm worried about the COVID virus, the coronavirus, I didn't get a chance to get the vaccination, whatever it is. So I'm not saying you can't disclose things to patients, but that's just an example I just used. I'm not, so disclosure, accepting gifts. Oftentimes, boundary crossings occur when you're caught off guard. So you're in a marketplace and someone comes up to you and begins to speak to you. You're picking up your dry cleaning, if anybody does that anymore. I'm not sure. We're not going to the office as much, but and you see one of your clients is helping you or whatever it is, whatever the situation is. A boundary violation is much more egregious and much more harmful and exploitive, and it's not in the best interest of the patient, it's in the best interest of the provider. So those are different definitions, different, sequela, different outcomes, different things lead to these. There's completely different motivation behind them, but I just wanted to acknowledge that, we all have boundary crossings. We have to sort of acknowledge and perhaps intervene on those and be open to feedback. But we have to really guard against any exploitation of clients. This is just a study that was done that said that individuals with the more severe sexual abuse the therapist had, the much more likely they were to violate others sexually and be more egregious in their boundary violations. So professional sexual misconduct. I mentioned the idea that individuals are impacted, organizations are impacted, and then licensing bodies are impacted. So many different organizations fall into this. So this is I can't read the title, but I do remember the article here. This has to do with, so you're sexually attracted to a patient. Now what? That's what the title is up here. This is taboo for us to talk about as clinicians. And the reality is, more than likely, at some point, we're going to have a number of different attractions to patients. And it's not always sexual or physical. We may be attracted to their charisma. We may be attracted to their creativity. We may be attracted to their financial acumen. We may be attracted to their style. There may be all kinds of things that we like about our client. And, sexual and physical attraction is certainly something that you may recognize this person is attractive. But where do you say that? Who do you say that to? There's a huge taboo for us acknowledging this in our profession. And so this is a really good journal article by Barnett talking about how this gets pushed aside and the ways in which we need to not be naive and say this isn't going to happen to me, and that somehow it defines us as being incompetent, and it's really about our character or the lack of ... whatever it is in our personal life. So trying to understand this can be very important and key to sort of responding to this and seeking out supervision. So this is an example I wanted to share, and this is actually an opportunity we're going to try to let people respond in the chat box, is what I'm assuming, Allie. We had spoken about this earlier. So I'm going to read this out loud, and I just want, if anybody cares to share in the chat box, I'd like to hear. We don't have to say your name, who you are, but we'll just sort of put your response out there and I'll comment on the response. So you live in a small community. You see a couple for domestic violence. She's a nurse. He's a police officer. The couple is doing good therapeutic work but there is still ongoing work to be done. And they have agreed to continue to work on their issues. One morning, you're running late for whatever, and you're stopped for speeding by your local law enforcement. The officer turns out to be your client and immediately refuses to write you a ticket saying, quote, "I am so appreciative of how helpful you have been to me and my wife," end quote. What do you do as a practitioner? So, Allie, I'm not sure if I have to end the slideshow to hear you.
No, you can hear me, right?
Yes, I can hear you. So I'll wait. We'll just wait a couple of minutes. I'll have a sip of my coffee here and see if anybody responds.
We are getting a few answers.
Okay, you want to start with the first one and just.
Of course, someone said working with a domestic violence couple is a no-no. Encourage officer to write the ticket.
Okay. Okay. So
Insist on giving me a ticket is what a lot of people are saying.
okay. All right. So the first comment is about the approach to domestic violence. And there are different approaches to this. There are different definitions of this. In some models, it's just working with the individual who's been battered. Other models may be inclusive of a partner. There's variations in it. But I respect that first comment. So the first one said, insist on writing a ticket. Was that right, Allie?
Yes.
Okay. So why are you any different than any other person that they may encounter, that the police may encounter? They may give people passes, warnings all the time. So I think because the person says, "I'm so appreciative of how helpful you've been to me and my wife," that's the alarm that I'm suspecting that most people are responding to. That, no, damn it, give me a ticket. Give me a ticket. It's like you get beaten on the table with a fork. I'm not so sure that's the best response, but I think any response is good. Because that's what this particular case is expected to do, is to bring up the possibility that we all would have a different type of response. And, some of us would say, "Thank you very much," and take off. Some of us say, "Give me a ticket. I'd appreciate a ticket." Some people may try to say, "Can you get somebody else here to give me a ticket, or to survey the scenario, or can I call your superior," or something like that on the side of the road. There's many variations of responses. I appreciate everybody responding in this media here, in this, the medium of technology. And the responses that you're having are very common responses. I think that it's key on the front end in this kind of scenario to let people know about your confidentiality and your policies related to seeing people in public, and how you will react to them and how you will not react to them. So if you have that and you reinforce it multiple times, that's probably the ideal. And then the other component here is that whatever decision you make, I think it's key that the next time there's a couple session, that this be brought up immediately so that the significant other, in this case the wife, is brought into the conversation and know that there was an interaction that took place outside of the office because of the alignment that may be perceived between the two individuals, that somehow we got something unique. I do think too that if it's like, thank you very much, then is there some expectation of like a quid pro quo or something? In this case, the assumption here is that the police officer is the batterer, and is the expectation that when there's a need to write a letter to the courts about this battered domestic violence situation, are you going to be favorable because you were let go of that ticket? So there's all kinds of possibilities that can come up for this. And, we're just bebopping along, running a little bit late. And then all of a sudden, like, I don't want to necessarily be thinking about all the therapeutic things I have to think about when I'm, trying to get to my destination or deal with whatever chores I have in hand at this point in time. So it's just I attempt to try to illustrate the reality of, the idea that we're often caught off guard with these scenarios. And here you have, it's good to be noble. To tell others how to be good is even nobler and a lot less trouble. So for those of you who took a risk and shared your response in the chat, that's very appreciative. I can't see the chat. I'm sorry. But I know that people put things out there per Allie's report. But I guarantee that a lot more people were on the sidelines and they were watching how other people were responding to this. And they would say inside, oh, I wouldn't say that. Oh, I wouldn't do that. Oh, so we have to watch being too judgmental in our response to our colleagues and our peers, because there's a lot of gray area here. There's a lot of things that inform this response, and we don't always know it all. So this is just a slide to try to express openness. And he wore some really weird bow ties. So I went to a training in Florida in 19 on site, so that was kind of the last times we were able to do that. And Marianne did a wonderful training about these different dilemmas, and she had us break up into small groups and have responses to them. So Allie has given me permission to give a little bit of a 5-minute break, so that but what I'm going to do is I'm going to leave this slide up for a 5-minute break, and I'm going to ask that people look at these scenarios, and if you have any response to any of them, to type the number that you're responding to, and then a few comments or a few words about the different scenario. And then I'll have Allie sort of read those off. So first I'm going to mute myself, and then I'm going to say we're going to be back here at, depending on your time zone, we'll do 35 after the hour, so 5 minutes. Okay, I got, can you hear me, Allie?
Yes.
Hello?
Hello? Can you
Allie,
hear
are you
me?
our wonderful host? Hello?
Hello? Can you hear me, Dr. Hemphill?
Can you guys hear me? Okay. She said, I can hear you in a text, so I'm going to keep going. So any responses to these scenarios? I think they're wonderful just to reflect on and to consider. Well, maybe since I can't hear her.
Can you hear me now, Dr. Hemphill?
Okay. Well, what I will say is that I just want to present you with possibilities of scenarios, and Marianne did a wonderful job of creating these, and I thought they were very um, important for people to consider in a variety of different ways. Um, ways to take care of yourself, sort of, consider all of our vulnerabilities at times, but make sure that these are just some examples of ethical scenarios here. Excuse me, this is one of the best models of ethical decision making that I've come across, even though it's 10 years old. So this was done in a, a group of researchers in New Zealand, and they came up with this boundaries in practice scale. And essentially, it asks um, clinicians to rate a scenario based on these four areas. I think it's a wonderful model to consider, and I use it in deploying it with students and supervisees that I may be supervising for the license. So the four areas are when we make a decision, an ethical decision, we have to have a certain fundamental knowledge, a base of knowledge. So we have to understand what we're being presented with. We have to know as I mentioned, our code of ethics and all these other things. Then, given the scenario, what is our comfort level with this particular scenario? So even with the police officer that we saw, it's like, how comfortable are we either saying, give me the damn ticket, or saying, thank you very much, or ignoring it, or whatever the response would be, or to some of those other scenarios. So what is our comfort level? And then have we had experience? Have we run into patients or clients outside of our practice? So our experience will often inform our response as well. And then we actually go through a decision-making process. But I want to acknowledge that there's certainly a knowledge base that we have to have a fundamental knowledge and have access to that. But we also have to acknowledge that when it comes to boundaries and ethical decision making, we have to have a certain level of comfort. We have to have certain experience. Therefore, the need for consultation often arises in some of these different areas, and then we can be talked through when it comes to the actual decision making process. And this is one example of a decision-making process, even though it's a long list here, but I think it's exhaustive. And so what I mean here is that, when you do a consultation, there's an issue here, consider the guidelines, examine the conflicts, try to resolve them as best as possible, consider some course of action that you're going to take, some remediation to this, look at some alternatives, be open to the alternatives. When you do select one, start to evaluate it as you implement it, and then understand what is the outcome of this particular response to this ethical decision. So it just sort of brings you through the actual decision making in this particular model. So what about when we recognize difficulties in our peers? Where are we with that? What is the right way to respond? What is the wrong way to respond? So here again, we're dealing with regards to addiction. We're looking at people's boundaries in the workplace. We're looking at people's behavior in the workplace. We're looking at peers who may or may not be responsive to what our feedback may be. We're looking at our own experience. Maybe we feel we might need to report ourselves for some wrongdoing. And it really is, it kind of depends. And if we acknowledge these things, we might say, well, there's a tattletale factor because professionals don't really rat each other out. It's, you're not really supposed to do that. Nobody likes a tattletale, you call a snitch or a fink or a narc or a dually or whatever. But, and we know that, hey, snitches get stitches, So this is just a reminder that we really are here to support each other. And there's a long history of help and supporting each other. And Dr. Weiss wrote about this from Palmetto, actually here in Louisiana, a few years back, about the history of help and how people have been reluctant to help each other historically, but that's not the case today. And we have to move past that. And we have moved past that, especially it's been highlighted with the pandemic, and that people are much more open to seeking out resources and seeking out assistance. And hopefully that's true in our daily lives and our daily deployment of care for our patients in the addiction field as well. I've already sort of mentioned a little bit about the digital age, but I do want to spend a few minutes commenting on this. And, there's a number of people. Fred Reamer has written substantially about this. And his more recent book, I actually got it may have just come out, but I was able to read a couple of chapters ahead. And it's really powerful in that we know that this just kind of crept in and that, clients prefer it even before the pandemic, but this is much more present today. And so some of the books that I've come across that I've thought have been very beneficial to this, and these are often written by people outside of the industry. However, Sherry Turkle is a psychologist who teaches in the artificial intelligence department at MIT. So she's brought all of that intellectual capital of psychology and integrated that into the idea of how do we deploy these resources and these innovative technologies, and how does that impact our functioning, not only as professionals, but also just as individuals. She's written quite a bit about. And so Thomas Friedman wrote The World is Flat, and he sat around and, this particular book, he talks about how he was waiting for someone and they didn't show up. And it gave him time to sort of gather his thoughts and start to put things down. So the concept of thank you for being late made him think, and instead of going into a state where we're constantly looking at things, like I'll find myself, forcing myself to not look at my phone when I sit down in a restaurant. If I'm having lunch by myself or even dinner or something by myself, I'll make myself not engage with technology to see what's going on around me. But these are some powerful. And then this this Rothblatt book scared the crap out of me, and that it really talked about how there are repositories now for, like, you could place all of your emails, text messages, pictures, websites that you've browsed, all of these things into a repository. And then 40, 50 years from now, your next generations, the future generations, can come back and recreate you and say, oh, this is what Philip Hemphill was doing at the turn of the century, or at, in 2020. This is all material. Now, I'm not really a TV watcher. I'm not really a movie watcher. I don't really watch series or any of that stuff. But my kids mainly, when I talked about this book that I was reading, they said, oh, there's a series on some of that. So I guess this is really common knowledge. I'm sorry if I'm boring you. But I just thought the book just scared the Jesus out of me, that somebody in the future was going to be recreated here. So, what digital does is it creates this kinship, this relaxing of boundaries sometimes, and that you may not be with your your professional clothes on in your professional environment when you respond. So there's all of this variability that can occur through technology. You may be in a grocery store or something like that. So just the social interactions are there, and being cognizant of what the expectations are in your practice and being clear about the limitations of confidentiality. And so people have, Sherry talked about that people have decreased face-to-face, they have increased discomfort face-to-face, and they have an increase in avoidance as they seek out more digital exchange, digital personas, digital expectation. And I've seen that in my own kids and different projects that they were challenged with in schools at different levels. And I watch them, and I sort of observe their more of their comfort level and the things that they avoid. And I do my best to guide that process. um, Social interactions are actually craved, and we've seen that substantially with the pandemic. And, so I think people taking to the telehealth is a welcome. They're like, really? Oh, wow, this is great. I get to have some interaction with an outsider and someone who is listening and caring for me and wanting more. So I always have people sort of reflect on this. So let's take a couple of minutes and think about your personal interface with technology. And I'll give you a minute or two to read this, and then if you want to comment in the chat as well, even though we won't have a discussion about it. But I still want to try to give you some time to reflect. Well, I think that as I look to my phone and look at the comments people are sending me, since I can't hear Allie, um, that these are pretty straightforward. I think us as clinicians should have maximum self-examination and be aware of our interfacing with technology. And then I usually have people discuss this with the person next to them, but that's okay. We don't have that option today. Just more on the reality. People check their phones 85 times a day. This was 5 years ago. It's probably more now. Spend 5 hours a day browsing. I mean, the early stages of the internet, people would have this dissociative sort of dissociative sort of amnesia where they would be like, oh, I only spent like 10 minutes searching for something, when in fact they spent 40 minutes searching for something. So I think that the realities are much more prevalent, that we know that there's oh, I'm going to go to this and this and this, and it just keeps going on and on. So awareness needs to be increased, and there obviously are some addiction implications here. Um, we know the negative effects of detachment in situations, but there's a lot of positives too, to increase communication. But we see some people who are gravitating to this source of communication. We see more anxiety and depression. So there are some ethical issues related to telepsychology. And in this book by Drogan, it's about the ethical issues related to it. Now, it is written by a psychologist, and it's for sort of the APA, but I think it's good to just sort of scan through these slides about the idea of confidentiality and the transmission of this information. That's certainly something that if your device gets stolen or lost, or let's say it stops working and you've got to bring it to a vendor to have this thing repaired, what happens with the information? How vulnerable is it to breaching confidentiality? Making sure that, the reality that there is a separation of physical space, that's something. So how do we deal with people who may be in a crisis or have a risk or be self-injurious? We have to have contingency plans in place to be able to address this. We need to maintain our competency level and know the latest information related to technology and apps and all of this stuff, and make sure we understand that we're adhering to the professional protected health information. We need to acknowledge in our informed consent that there may be limitations, like who's going to be present on your end, who's going to be present on my end. What if somebody walks in? What if somebody doesn't? What about you're borrowing a computer? All these different things. Is this being recorded? All of these possibilities here. So really about the competency here for us, our awareness. And so there are many CEUs and guideline reviews related to dealing with crisis telehealth, dealing with ethical decisions in telehealth. That's not what this presentation is about, but in overall, it behooves us to get informed related to this, as this become much more prevalent in our industry now. So again, more criteria for your policies and procedures and safeguards to decrease your legal risk, and looking at how the reality is not all jurisdictions behave the same way. So in one place, you may be considered okay. I know there's been some broad stroke policies and laws put in place by the government and by lots of insurance companies, but they've clawed back some of that. Even January 1st, some of that has been clawed back, and in a sense that people may not be able to do some things that they were doing during the pandemic. So making sure you stay up to that is very important. These are some more of Reamer's book is 21. It's at least 2020, his newest one related to this topic. But these are just some of the ones I put up at the very beginning. So some of my suggestions from this article, which predates the pandemic, which I think is great, because it really speaks to how you should maintain professional hours if you're going to have telepsychology, telehealth, being respectful of the timing of the sessions, ensuring that there's constant feedback and not excessive communication going on, and managing excessive communication so that you can get a clear understanding of these things. Making sure the privacy, I've already mentioned that, and the privacy of outsiders, and making sure that you have clear communication. Like say, for example, today, Allie, I told her that if something goes on with my internet, I will call in on my cell phone. I will do the verbal, I will give the auditory to it, but I'm going to have you rely on the slides and go from one slide to the next. So I have a contingency plan here if somehow the technology fails today. So, modeling appropriate boundaries, self-boundaries, that's healthy, especially in a pandemic, talking about the importance of boundaries continuously, and using professional language, even though it's on the computer, doing your best there, and, again, the competency. There's been a lot of apps coming online. There's actually a recent article, or actually there's a recent review, American Psychological Association. You can go to their website and see they have a way of vetting apps, what you should do as a clinician to consider if this app is appropriate for making the recommendation. Because clients will bring apps to you, come to you with things and say, what about this? What about this? What about this? You have to watch endorsement of these different things. So just, accessibility, being available in real time. Those are some of the mental health apps advantages to that, and some of the ways in which things are being treated. Some organizations were polled a couple of years ago by NetSmart. It just said, how much technology do you have in place? Is this in the works? And or do you not have any plans at all? Now mind you, this is pre-COVID. So, you have people saying, even, pre-COVID, that wearables are on the roadmap, meaning like we're about 76% saying we want to employ wearables. And about 23% saying we're not interested in doing that. But you can see that using apps for eCBT seem to certainly have a predominance there. Text-based therapy, kind of possibly. With people, there's text-based, which is asynchronous, which means that a person texts in or writes in, and then the therapist spends time at a different time responding to that person. And then synchronous would be live telehealth that takes place. So these are just some of the ways in which organizations reported their interface related to technology. And I think it was interesting because it was done before the pandemic. And so I'm sure a lot of this has been accelerated in organizations. And then, in the middle of last year, the FDA permitted the first game-based digital therapeutic to deal with attention functioning in children and with ADHD. So really acknowledging the use of technology to blend in the care for kids and sort of building on their engagement points to treat these things. Again, this is a way to stay ahead of the game. What are some of the apps that I've sort of looked at that I think are beneficial? One of my colleagues has this platform, Synchronous Health, where there's a bot called Carla, and kind of people in recovery, and it's sort of they're able to have content from the data that the person is physically. It's able to email and chat their support system. So maybe say on a Wednesday, if they're laying on a couch and they haven't moved, they may get a ping that says, hey, aren't you supposed to be at work or school? And sort of it's like a risk situation related to recovery and healing. So again, there's a number of platforms for this, but this is some more information about how there's measurement increase, there's screen connection, there's engagement, and then it matches. So here's another scenario. You're walking down the hall, you overhear one of your coworkers discussing a case, laughing and saying what a pain the client is with someone from another section or department. When you say something to the coworker, they say, he in this case says, what's the big deal? This person's a drug court employee. So I'm going to give you a second to make a response here. Any thoughts about how you would respond if the person was sort of discussing a case with someone outside of the section and laughing and saying about what the pain, how much of a pain this client is.
Dr. Hemphill, can you hear me?